Well, thanks everyone for inviting me to talk. There's a few familiar faces, a few not familiar. There's going to be a bit of overlap between Simon's talk and my talk. Obviously, my brief was to talk a little bit about treatment, so that's going to be the main thrust of it. It's a pretty picture of the brain that it's called diffusion tensor imaging. It's when we were doing some optic neuritis research. Looks very pretty. I guess when you're dealing with a complex disease with lots of manifestations, it's important to have a team approach, and a team approach is vital. I don't know who I'm not sort of a bit ugly and... Geez, I wish I could be muscly like the Hulk, but sadly not. There's no sort of little dweeby, nerdy guy there, which is probably me, but anyway. So for MS and NMO, the team often overlaps, and obviously nurses, rehab specialists, bladder people, psychology, pain specialists are all very important. So a team approach is really important. I was just going to present a case of someone who's not here, unfortunately, but a pretty typical story that you probably rings a lot of bells with people present. This was a 60-year-old lady who presented to the hospital with quite a dramatic onset, sudden onset of weakness, sensory disturbance, so pins and needles, numbness, tingling that spread up the body from the legs, and eventually came up to the chest over a few weeks. And then suddenly the bladder went to sleep, couldn't pass urine, terrible constipation. The GP saw her in a little country town and realised that something very bad was going on, so immediately sent her to hospital when she was transferred down to the Royal Melbourne. And there was unfortunately significant leg weakness, quite devastating. And it was, as Simon mentioned, it was symmetrical, so both legs were affected rather than just one. And there was sensory loss, so loss of feeling, all the way up to the chest. Quite frightening stuff. This is a picture of her MRI. So as Simon mentioned before, the orientation's in this way. So it's as if we've sort of taken a samurai sword and chopped someone in half. So front is here, that's the sternum, and the skin of the back's here. These are the sort of more structural elements to the spine, the sort of where you get all the strength and movement from, the bones with the discs between, so the vertebral body. And then the spinal canal is this area down here with the spinal cord in the middle, and it's a very protected organ. It's the most important nerve in our body. And this slice here probably demonstrates it the best, where you can see that up here the spinal cord's nice and grey, and then as we come down here around the shoulder area, it's all swollen and inflamed and a lot of white colour in there that shouldn't be there, just there. And it was quite a long segment, as we see with NMO. So next slice. Not much down here. This is what it should look like. So it should be nice and dark, and there should be water front and back. The white here is the water, there and there, and the spinal cord floats in a little sack full of water. And sometimes when we're trying to diagnose people, we pop a little needle in here called a lumbar puncture needle, which many people are familiar with. Now we can't hit the spinal cord, very important. Everyone says, oh, you can hit my spinal cord. We can't hit the spinal cord. Spinal cord ends here at L1, and we go down here below it at L3, 4. This is with the dye injection. So this particular cord lesion's lighting up with the dye. You can see that the normal cord here doesn't light up with the dye, whereas the cord up in the damaged area is inflamed and the dye is leaking into the damaged tissue. Now here's some pictures in the opposite sort of orientation. This is just as if we're slicing up this way, like a sausage. And in this orientation, the front of the body's there, so the chest, back of the body here between the shoulder blades, R for right, L for left. there's the spinal cord there in the middle with this central spinal cord lesion there. That white area there shouldn't be there. And NMO often causes those central cord lesions. Here are the lungs. The right lung, left lung, and there's more inflamed spinal cord there. It's a level of T3, which is sort of right between your shoulder blades. And hers extended a little further down too. Now, this is the lumbar puncture that I mentioned. Here's just a little diagram of what happens in a lumbar puncture. So people lie on their side usually. Occasionally we do them seated, but doing them on the side gives much better information about the pressure within the brain and the spinal cord area. And we pass a needle between the bones of the spine, puncture the little sac that the nerves float in, and take off some of the fluid there and analyse it. In this particular case, the protein levels were high, as were the antibody, the total antibody levels. But there's this other funny thing that we measure called oligoclonal bands. They're negative, as they often are in NMO. And the cell counts were mildly elevated. There was inflammation there. Sometimes these can be quite highly elevated, the cell counts. So this lady had the typical treatment for NMO. She had high-dose steroid. So I'm just going to sort of break up treatment into acute treatment, so when people have a relapse or when they get sick, chronic sort of suppressive treatment, and then another big area, symptomatic treatment, which is treatment for pain, stiffness, and symptoms rather than trying to suppress the disease. So the typical treatment is high-dose steroids. People often get a metallic taste in the mouth. They often get insomnia. They often get an amazing feeling of energy. But consequently, sleep's often poor, so we often give people a script for some sleeping tablets as well, just to try and help get through that terrible insomnia. Unfortunately for this lady, her symptoms got worse, as sometimes they do in NMO, and she had a treatment called Intragam, and that is pooled antibody from blood donors, very important treatment. And her antibody test came back positive for that NMO aquaporin 4 antibody that Simon just mentioned. Now, this is a drip given 5 days in a row, dribbles in quite slowly, and it has some side effects, but overall it's pretty safe. It's from screened blood donors, and they're checked for HIV and hepatitis and infections. The other acute treatment that is can be very effective, and one that we would use a bit more frequently now rather than the antibody one, is this treatment, which is called plasma exchange. I guess it's a bit like dialysis, where you get hooked up to a funny looking machine that filters the blood, and this can be quite effective for treating acute attacks. So basically you need large volumes of blood to go quickly through the machine, so you need a big drip. So you'll either have 2 big drips in the elbow, or a bigger drip in the shoulder or in the groin that has sort of a bigger tube going in. And with that, people get attached to the machine, and the blood gets washed through this device here, which has got a number of little filtration steps to take off the bad antibodies and give back good proteins. And so this lady had steady and slow improvement. One leg was picking up faster than the other, but she's still quite disabled and needed to go to rehab for quite a few months. She's had ongoing problems with nerve pain and has needed a number of different medications to help control that. And also the bladder's been a problem, and she's had to use catheters, unfortunately. And she had a long stay in the spinal rehabilitation ward. So that's a little bit about sort of the acute setting with a relapse, and that was all pretty bad. So how the hell are we going to prevent that? Well, we prevent that by suppressing the immune system long term, and sadly our first go-to drug very, very old drug, is steroids, and they have terrible side effects: weight gain, puffiness, moodiness, thinning of the bones, blood pressure. The list goes on and on and on, and it's so frustrating and upsetting for people with the steroid side effects, but unfortunately they are very effective at controlling the disease initially. So they're a necessary evil which we sometimes have to continue on for quite a while, and typically people would be on them for maybe 6, 12 months, maybe even longer. It just depends on how things go. It's such an unpredictable disease. Some people can get off them, some people are stuck with them, sadly. Now, to try and mitigate that sort of effect with those terrible steroid side effects, we've got a number of other immune suppressive drugs that we can use. They all sort of suppress dividing cells, immune cells. The old workhorse, Imuran or azathioprine, quite effective. It can have problems with its breakdown, so sometimes we have to, most of the time now, we'll check people for their enzyme breakdown of that drug before starting it. Some people are very sensitive to it and their blood counts will drop through their boots. But as long as people don't have that funny mutation, most people tolerate the Imuran well. Another one is methotrexate, a drug that's used for other immune disorders, as is Imuran. And more and more now we're using this drug, mycophenolate, which is really easy to use. It was quite expensive up until recently. It's recently come off its patent, so the price of it has plummeted with all the generics, and so that's a lot more accessible now. It used to be only available to people with transplants and so forth. Now, another very effective therapy, which I heard that some people were on around the room and that is used frequently, is rituximab. This is an antibody therapy. It's made in a laboratory and given periodically every 6 months. Very effective for many immune disorders, including NMO and MOG. And being an older antibody, it's got some mouse DNA in it. When you make an antibody for your therapeutic purposes, in the olden days it was very hard to make. And so the off-the-shelf antibodies still had a bit of mouse in them, which sounds bizarre. But most of the new ones are sort of got human DNA in them. And that's a lot better tolerated, surprisingly, than mouse DNA. So allergy's a problem with this infusion, and people get given some steroid and some antihistamine to try and reduce that effect. Now, obviously, when you suppress all the immune cells, some of them are goodies and some of them are baddies, and some of the goodies take a hit, and so infections can occur. Sally's going to go into psychological symptoms. Very important to help counsel people through these tough times. Mood problems are very common, and we use mood medications as well as counselling and support. Nerve pain, very common in NMO, terrible nerve pain, a big problem. And there's, sort of quite a few different nerve pain drugs that get tried. They've all got their problems. Lyrica, weight gain, the mad munchies we call it. And I guess when you're immobile and can't exercise, that's the last thing you want is the mad munchies. But there's other ones we use too. Some of them are used for other things, and two drugs that are used for depression are quite good nerve pain drugs too, Endep and duloxetine. And people say, "What are you giving me this for, Doc? I'm not depressed, am I? I'm over the world." Anyway, they can be helpful for nerve pain. And bladder symptoms, common as well. And we've got some bladder relaxing medications, Ditropan, Vesicare, and this brand new one, Betmega, much less dry mouth, very good drug, but bloody expensive, sadly. And then other techniques that the urologists help us with, catheters and Botox into the bladder wall can be quite helpful. Simon mentioned this chap, Devik, who published initially on NMO. And what medical talk would be complete without a complicated diagram, just as Simon mentioned, with lots of arrows pointing in all different directions, lots of cells, antibodies. But basically, this is sort of the story of NMO, where there's pathological antibodies attacking water channels on cells, causing the damage. That was about all I had to say. I think we were going to leave questions to the end, but thanks for your attention.